Hypertension is defined as a sustained elevation of the systemic arterial blood pressure, and it's usually defined as a systolic blood pressure of greater than 140 millimeters of mercury or a diastolic blood pressure of greater than 90 millimeters of mercury. The systolic blood pressure being the pressure in the arterial wall with contraction of the heart, and the diastolic is the pressure in the blood vessel wall with relaxation of the heart. There are several ways to classify hypertension. The most common one is into the causes, which are primary or secondary hypertension. Primary hypertension is also known as essential hypertension. That is defined as hypertension when there is no underlying cause found. This is the most common type of hypertension, encompassing 90 to 95% of all cases of hypertension. And the underlying cause is unknown, but it is thought to be multifactorial due to combinations of genetics and environmental contributions, such as risk factors, which we will cover below. Secondary hypertension, on the other hand, is hypertension that is due to an identifiable underlying cause. So there is a separate medical condition that is driving the patient's hypertension. Hypertension can be classified into different severities based on the level of either the systolic and or the diastolic blood pressure, and this is taken from the 2016 Australian Heart Association guidelines for management of hypertension. So optimally, blood pressure should be less than 120 systolic and less than 80 diastolic. And the normal range can go up all the way up till 130 systolic or 85 of diastolic. The high end of normal is a systolic of 130 to 139 or a diastolic of 85 to 89, which means that any blood pressure that is a systolic of greater than 140, so 140 or greater, or a diastolic that is 90 or greater, is considered as hypertension, with grade 1 being 140 to 160 systolic, grade 2 160 to 179, grade 3 180 or greater, and on diastolic it's 90 to 99, 100 to 109, and grade 3 is greater than 110. So systolic increases, each grade increases in 20 increments, whereas diastolic increases by 10. There are also different ways to classify hypertension based on the blood pressure readings of the patient, whether they are in the clinic or outside of the clinic. So you have white coat hypertension, where you have blood pressure that is high in the office, but it is normal outside of the office. You can also have masked hypertension, which is the opposite of white coat hypertension, where the blood pressure in the office is normal, but the blood pressure outside of the office is high, which is why it's called masked hypertension, because you as the clinician may not pick this up because their blood pressure when they come to see you in clinic is normal. Whereas white coat hypertension is something that is more easily picked up because the blood pressure by definition for white coat hypertension in office is elevated. There is also a class of hypertension called resistant hypertension, where the blood pressure is elevated above target, and that's usually greater than 140, despite using 3 different antihypertensive drugs, each of which are from different class. And to fit the definition of resistant hypertension, out of the 3 different antihypertensive drugs that you are using, one of which has to be a diuretic. So this here is a table which helps to sort out the different types of hypertension based on the clinic and out of clinic readings. So if you have a high office blood pressure and a high out of office blood pressure, then that patient will have true hypertension. Whether that's primary or secondary hypertension will depend on the workup. If they have a high office blood pressure but a normal out of office blood pressure, then that is called white coat hypertension. They basically have a raised blood pressure because they have a raised sympathetic response to being in a doctor's office. If you have a normal office blood pressure and a high out of office blood pressure, then this is masked hypertension. And if you have normal office and normal out of office blood pressure, so at home the blood pressure is normal, in clinic the blood pressure is normal, then the patient doesn't have high blood pressure, they just have normal tension. To understand hypertension, there are a few physiological principles to cover. Although the underlying mechanism of essential hypertension is unclear, I think understanding these physiological principles helps to understand the factors driving blood pressure and to also help understand the pharmacology in the management of hypertension. So blood pressure is can be defined by the formula of the product of cardiac output multiplied by the total peripheral resistance. So cardiac output in turn is determined by the heart rate and the stroke volume. Heart rate will be determined by the balance of autonomic inputs into the heart, into the sinoatrial node, by the sympathetic or the parasympathetic nervous system. The stroke volume, likewise, is determined by the sympathetic nervous system, which affects the cardiac contractility, so how hard the heart is squeezing to pump blood out. And stroke volume is also determined by the blood volume. Blood volume, long term, is determined by salt and water balance, which are mediated by the renin, angiotensin, aldosterone system, and the ADH system. In terms of blood pressure pharmacology, the RAS is the one that's more clinically relevant. Total peripheral resistance is determined by the radius or the size of the arterioles. The smaller the size of the arterioles, the higher the blood pressure, and the more vasodilated the arterioles are, the lower the blood pressure, because blood pressure is inverse to volume. The size of the arterioles is determined by the sympathetic nervous system. When you activate the sympathetic nervous system, it causes the smooth muscles in the vasculature walls to contract, thereby reducing the diameter of the arteriole, thereby increasing blood pressure. And the arterial radius is also influenced by the angiotensin 2 enzyme that is part of the renin angiotensin aldosterone system. As the name suggests, angio referring to blood vessels, tensin referring to tension, and so angiotensin increases blood pressure. Next we'll go through the RAS, which is the renin angiotensin aldosterone system. So the RAS system starts in the kidneys, whereby the kidneys will produce renin in response to three different stimuli. The first is when there is a reduced delivery of sodium, and this is picked up by the macular denser cells in the distal convoluted tubule. Renin is also released by a reduced renal perfusion pressure, and it also is released by the stimulation of the juxtaglomerular apparatus by the sympathetic nervous system, as the juxtaglomerular apparatus has beta-1 receptors which respond to noradrenaline released by the nerve fibers of the sympathetic nervous system. All three of these stimuli, reduce sodium, reduce kidney perfusion pressure, and SNS stimulation, you can imagine, all occur in states of low blood pressure and low blood volume, and therefore the renin angiotensin aldosterone system aims to increase blood pressure and blood volume. So reduce sodium, reduce renal perfusion pressure, and stimulation of the juxtaglomerular apparatus by the sympathetic nervous system leads to a production of renin by the kidneys. Renin in turn will cause angiotensinogen, an enzyme a protein produced by the liver, to be converted into angiotensin 1. Angiotensin 1 will be affected by the angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. And angiotensin 2 has multiple effects to try and raise blood pressure and blood volume. The first is that it stimulates the secretion of aldosterone from the adrenal cortex. Aldosterone increases the reabsorption of sodium by increasing the amount of the epithelial sodium channels in the collecting duct of the kidneys. Higher amount of sodium reabsorbed leads to more water being reabsorbed through osmosis, and therefore that increases blood volume, which increases stroke volume. And stroke volume, as we know, increases cardiac output, which increases blood pressure. Aldosterone also causes the excretion of potassium, and this happens because when sodium is reabsorbed by the epithelial sodium channel in the collecting duct, there is also a separate exchange pump called the sodium-potassium exchange pump that will secrete potassium in order to maintain one positive charge in for one positive charge out. Angiotensin 2 also causes direct sodium reabsorption in the proximal convoluted tubules. It, as its name suggests, leads to vasoconstriction, which increases total peripheral resistance. It also stimulates the release of ADH from the pituitary gland, which causes water to be reabsorbed by increasing the amount of aquaporin 2 channels in the collecting duct, and that also increases blood volume and stroke volume. An antidiuretic hormone is also known as vasopressin, but it only really exerts an effect on total peripheral resistance at very high amounts of ADH being secreted. The next one is the antidiuretic hormone, which is ADH or vasopressin, and ADH is secreted in response to increased plasma osmolality There are osmoreceptors in the hypothalamus which will pick up on the amount of solute and the concentration of the bloodstream. So if you have a high sodium and low water, that causes a raised plasma osmolality, which will release ADH from the posterior pituitary. The other way that ADH is secreted from the posterior pituitary is a reduced blood volume, and the reduced blood volume is picked up by baroreceptors which are located in the carotid sinus and the aortic arch, which simulates the release of ADH. The purposes of ADH is to, one, drive down the osmolality of the serum and also to increase blood volume. Once ADH is secreted by the posterior pituitary, it acts on the kidneys at the distal collecting tubules and the collecting duct, which increases aquaporin channels, leading to sodium reabsorption, more blood volume, more stroke volume, and more water being reabsorbed dilutes the bloodstream and therefore also decreases plasma osmolality. As mentioned, ADH is also known as vasopressin, and it can also act on blood vessels to cause vasoconstriction if there is a high amount of ADH, which you typically don't really see unless the patient is extremely dehydrated, and that can lead to an increase in total peripheral resistance. The last concept, which isn't driving chronic hypertension but more to understand the adrenoceptors involved in the pharmacology of hypertension, is the baroreceptor reflex, which usually which regulates short-term blood pressure, not so much chronic. In patients with hypertension, the baroreceptor response is set to a higher threshold so that it doesn't bring down blood pressure when it should, because the homeostasis has been altered. So as an example, if you have low blood pressure, you have low blood volume, and that is picked up by the baroreceptors in the carotid sinus and the aortic arch, and that sends signals to the cardiovascular center located in the medulla. This then will trigger an increase in the sympathetic nervous system activity, and it acts on both the effector organs of the heart and the blood vessel. In terms of the heart, it increases heart rate by stimulating the beta-1 receptors, and it also causes cardiac contractility by the same beta-1 receptors. And as we mentioned before, an increase in heart rate and an increase in cardiac contractility leads to an increase in cardiac output. Vasoconstriction is mediated by the alpha-1 adrenoreceptors, and that is going to increase total peripheral resistance by vasoconstricting the blood vessels. There are also alpha-2 receptors that are mediated by the sympathetic nervous system, and agonism of the alpha-2 receptors leads to vasodilation. What are the risk factors for hypertension? So risk factors for hypertension will be age. The older you are, the more stiff the blood vessels get, and therefore the higher the blood pressure. Obesity and family history will also be risk factors for high blood pressure. A high salt diet, you can imagine more salt in the diet leads to more resorption of water, more water reabsorption, more blood volume, more stroke volume, higher cardiac output, and higher cardiac output, higher blood pressure. Excess alcohol also causes an elevated blood pressure. So alcohol increases blood pressure as it directly stimulates the sympathetic nervous system. Alcohol also has been shown to stimulate the release of renin from the kidneys, which, as we know, downstream leads to angiotensin II, aldosterone, sodium reabsorption, and vasoconstriction. Smoking also stimulates the sympathetic nervous system and also causes inflammation and direct damage to the vascular endothelium. Physical inactivity, sleep deprivation, a history of gestational hypertension or preeclampsia also predisposes you to developing chronic hypertension outside of pregnancy, and diabetes as well. So hypertension and cardiovascular disease risk. So why do we care about hypertension? So we care about hypertension because of all the risk factors that drive cardiovascular disease, hypertension is the most common one. It is also one that can be easily treated and can be easily modifiable, and therefore reduce the risk of the development of cardiovascular diseases quite significantly. And for every increase of a systolic of 20 or a diastolic of 10, it essentially doubles your risk of cardiovascular disease. On the other hand, if you decrease blood pressure by a systolic of 5, you also reduce the rate of cardiovascular events, heart attacks, strokes, by 10%. So before moving on and talking about the evaluation of normal hypertension, I think it's important to talk about masked hypertension, as well as white coat and resistant hypertension. So masked hypertension is, as we covered before, where your blood pressure in the clinic is normal, but the patient's blood pressure outside of the clinic is elevated. It occurs in 10 to 30% of adults with normal office readings, which is quite common, more common than I would think. And the risk factors for masked hypertension are basically anything that would cause the patient's blood pressure to be driven to be high chronically. So even when they're outside of the clinic. So chronic kidney disease will obviously interfere blood volume, sodium reabsorption, and that can lead to masked hypertension. Diabetes as well, obstructive sleep apnea. All three of these diseases increases the risk of nighttime hypertension. Smoking, high stress and high sodium diet. So these are all factors that can also drive hypertension. And so if you see a patient who has multiple risk factors for hypertension that we covered above, and their blood pressure is normal in the clinic, then you might need to think about, okay, is this because they don't have hypertension, or because they have high blood pressure outside the clinic that you're not picking up on in the clinic? So think about masked hypertension. If you see a patient with multiple risk factors for hypertension, and yet their blood pressure in the clinic is normal. So when do we suspect masked hypertension? We suspect it when patients have risk factors above with normal office blood pressure, and they have target organ damage present despite normal office blood pressure. That is, if you have no other way of explaining the target organ damage. So for example, if a patient has chronic kidney disease, they have proteinuria, or they have peripheral arterial disease, they have left ventricular hypertrophy, you do a full workup and you can't find any other reason for them to have those particular target organ damage, then think about hypertension, especially masked hypertension, as being one of the causes. We investigate masked hypertension by performing ABPM, which stands for ambulatory blood pressure monitoring, or HBPM, which is home blood pressure monitoring, as these two will be able to pick up blood pressure outside of the clinic. Why we care about masked hypertension? And we care about masked hypertension because if we don't pick up masked hypertension, the patient actually has a diagnosis of hypertension, and then therefore they have the same risks as patients with hypertension, and yet they are not diagnosed, and therefore they are not treated, their risk is not controlled, and their rate of cardiovascular disease complication remains elevated. White coat hypertension is a bit more straightforward because it will always present with a elevated hypertension or elevated blood pressure or hypertension in the clinic. However, their blood pressure outside of the office is normal. Why we care about white coat hypertension? Although white coat hypertension doesn't carry the same amount of risk in terms of cardiovascular disease compared to a patient with true hypertension or masked hypertension, they still have a high cardiovascular disease risk than patients who have normal blood pressure. Patients with white coat hypertension are also at an increased risk of developing true hypertension. You can think of it somewhat like pre-diabetes, where you have a patient who has an elevated fasting hyperglycemia or impaired glucose tolerance. They do not yet have an out-and-out diagnosis of diabetes, but they're at risk of developing it. I think the same sort of concept can be applied to white coat hypertension. For white coat hypertension, you don't need to initiate any drug therapy, unless of course their in-office blood pressure is really high. And so the main management focus for white coat hypertension is lifestyle. So you manage them through lifestyle and also by regular monitoring of their blood pressure in order to pick up on any early development or diagnosis of true hypertension. The last one to cover is resistant hypertension. So to talk about resistant hypertension, we need to also talk about pseudo-resistant hypertension. So pseudo-resistant hypertension is where the patient appears to have resistant hypertension, that is, their blood pressure is uncontrolled, but it's not because it's uncontrolled for reasons that we cannot identify, but rather it is uncontrolled due to non-pathological causes. So there are other factors that are driving the patient's apparent uncontrolled hypertension. And the four main common causes of pseudo-resistant hypertension will be 1, poor medication or adherence to lifestyle treatment. Number 2, inaccurate measurements of blood pressure. Number 3, white coat hypertension. And number 4, the patient is just not having an optimal treatment. That is, the doses or the medications that they're on are suboptimal. And so they don't actually have a true uncontrolled blood pressure. They just have different factors that make it look like they have uncontrolled blood pressure. So looking at the first one, poor medication and lifestyle adherence. If they adhere to the medication, then they might not have uncontrolled blood pressure. Their blood pressure might be well controlled if they adhere to medication and lifestyle. Likewise, if you're measuring the arm with a very tight or too small of a cuff, then it always looks like they have hypertension when they might not. I mean, they may still have hypertension, but they could still be controlled. Whereas if you're squeezing them with a cuff that is simply too tight, they will always look like they have hypertension. Microhypertension, as mentioned before, and suboptimal treatment regimen is common sense. If you don't dose them appropriately, you give them medication doses that are too low, and they still have high blood pressure, then you need to try to increase the dose first before you can say that it's uncontrolled with maximal therapy. True resistant hypertension is when you have an elevated in-office blood pressure and an elevated 24-hour ambulatory blood pressure monitor. So their blood pressure is both elevated in the clinic and outside of the clinic. So they don't have masked hypertension, they don't have white coat hypertension, and they don't have any other factors that contribute to pseudo-resistant hypertension. So the patients are really adherent to lifestyle, they're really adherent to their medications, you measure their blood pressure correctly with the correct cuff size, you've ruled out masked hypertension, you've ruled out white coat hypertension, you've treated the patient with optimal doses of optimal antihypertensives, and yet they still don't have a controlled blood pressure, then that is when the patient has true resistant hypertension. The clues to true resistant hypertension is when the patient presents with a high baseline blood pressure, such as a systolic of above 180, or they have left ventricular hypertrophy, because then that's a marker of hypertensive target organ damage. So true resistant hypertension is often due to secondary causes of hypertension. So there is something else going on with the patient that is causing them to have hypertension, and unless you find out what that is and unless you treat it, the patient will have hypertension. And so in all cases of resistant hypertension, you need to consider secondary causes of hypertension. So before we can treat hypertension, we need to diagnose hypertension. And in order to diagnose hypertension, you need to measure the blood pressure correctly, both in clinic and out of clinic. So we'll start with in clinic because that is when you will pick up a patient who has hypertension. So the frequency, how often you measure a patient's blood pressure when you suspect that they have hypertension, or whenever you want to measure a blood pressure, is that a blood pressure must not, the results of a blood pressure must not be taken in isolation. You need to have multiple blood pressure readings on multiple different occasions. So you want to measure the blood pressure on at least 2 separate occasions. And on each occasion, you need to take 3 readings and you average the last 2. And when you are taking each measurement, you need to wait 30 seconds between repeat measurements. Otherwise, the patient's blood pressure will be elevated, not because they have hypertension, but because the cuff has been squeezing their arm and you haven't given them enough time to rest. To prepare the patient for a blood pressure measurement, they need to be seated and relaxed for several minutes, 2 to 3 minutes in a quiet environment. That's usually not very possible when you only have 15 minutes with the patient. You're oftentimes just rushing and wanting to measure their blood pressure straight away. But ideally, the patient needs to be seated, relaxed, several minutes in a quiet environment. Their arm has to be resting at the level of their heart. Their back has to be supported against the chair, and their feet, both feet, have to be flat on the floor. The patient must not be talking during the measurement, which can be tricky because patients like to share their day with us, and the patient must also not have had any coffee or smoking or any food or any exercise 30 minutes before, because all these factors will elevate blood pressure, so you're not getting a true reading. So this image is a very good diagram. So no smoking, caffeine, food, exercise 30 minutes before, quiet room, comfortable temperature, resting for 3 to 5 minutes beforehand, no talking during or between measurements. Cuff that is appropriate size, which we'll cover later, back supported, feet on the floor, arm on the same level as the heart. Next is the cuff selection. So cuff selection is very important. You need to use the correct size of the blood pressure cuff, and this is based on the patient's arm circumference. You measure the patient's arm circumference in the mid-arm, and based on the patient's arm circumference, you can choose the blood pressure cuff that is of the correct size for them. The other way to tell is blood pressure cuffs often have marks on them, and the mark has to fall within a certain range. If it's too low or too high outside of that range, then the cuff is too small. So you can see here that there's a range of the blood pressure cuff, which this line should fall into when you wrap the cuff around the patient. And if it falls outside the range, then the cuff is either too small or too large. So you wrap the cuff around the mid-arm, the mid-upper arm. The bladder midline is over the brachial artery. So bring out that image again. Oh, nope, that's not the image. So there's this indicator here. You should put that over the patient's brachial artery, and you should have at least sort of 2 finger gap between the bottom of the cuff and the elbow crease. If you're measuring the patient's blood pressure using an automatic device, make sure that the device is certified and it's calibrated and it's working properly. If the patient has an irregular pulse, then you need to measure the blood pressure manually, because the automated blood pressure machine will not be able to differentiate whether the croak-cough sound is present from an irregular pulse or a regular pulse. And so if you measure the blood pressure manually, you need to deflate the cuff slowly. You need to auscultate over the brachial artery. The systolic blood pressure is defined as the appearance of the croak-cough sound, so the first douche sound that you're hearing. And the diastolic blood pressure is the disappearance of the croak-cough sounds. The common sources of error of measuring blood pressure is incorrect cuff size, so using a cuff that's too big or too small. If the cuff is too big, it's going to squeeze the patient's arm way too tight, and if the cuff is too small, it's not going to squeeze the patient's arm at all. And so a too small cuff causes an overestimation of the patient's blood pressure, and a too large cuff causes underestimation of the patient's blood pressure. The second common source of error is that the cuff is placed over the patient's clothing. I mean, if the patient is very loose, non-restrictive clothing, that probably wouldn't matter too much. But if they're wearing, for example, a jacket, then you're not squeezing the arm correctly because their sleeves are in the way. Other common sources of error is the patient is not rested. They've just come in running into the clinic because they are late for their appointment, or they've had 2 shots of espressos beforehand, or they're talking during the measurement, or they're moving during the measurement, and so that are also common sources of error. And the last one is taking only a single measurement. The first measurement is usually always the highest, and that's why it's recommended to take 3 and average the last 2, because that will give you the most accurate in-clinic blood pressure measurement compared to only taking 1. If you take 1 blood pressure measurement, it's usually higher than the patient's true blood pressure. How do we measure the blood pressure outside of the clinic? So we can measure the patient's blood pressure outside of the clinic by two methods. The first is the ABPM, so the ambulatory blood pressure monitoring. This is where the patient wears a portable device for 24 hours. The device will cycle and measure their blood pressure every half an hour or so. And this goes on throughout the day and at night. And what you tell the patient when they have this device on is that do all the usual things that you would do during the day. But when the blood pressure machine starts to cycle and measure your blood pressure, just remain still with the arm relaxed when measured. If it starts to measure the arm at an inappropriate time, usually you can cancel it so that you don't get an inaccurate reading. Next is the home blood pressure monitoring. So make sure that the patient uses a validated device. The patient has to be prepared in exactly the same as for if you would measure the patient's blood pressure in office. So, no smoking, no coffee, resting, blah, 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 feet on the floor, arms supported, relaxed, use the correct cuff size. And when you educate the patient on how or when to take blood pressures at home, you ask them to take the measurement in the morning and in the evening, because it gives you a better average of their blood pressure over a 24-hour period rather than just having only in the morning or only in the evening. You ask them to take their blood pressure before their medications, because you want to see the blood pressure before the effects of the medication, and also before food, because certain foods can raise blood pressure. You ask them to take 2 measurements each, 2 in the morning, 2 in the evening, and 1 minute of resting in between. If you want to diagnose hypertension in the patient with home blood pressure monitoring, then you ask them to measure it for at least 3 days, ideally a week. So 2 in the morning, 2 at night for 3 days. But if the patient has already been diagnosed with hypertension and you want to monitor their response to treatment, then you can get the patient to do it at least once or twice a week. The more numbers, the better, but it depends on your negotiation with the patient. When would you order out of clinic blood pressure measurement? So when would you order an ambulatory BP monitor or a home BP monitor? Basically, almost always, almost all the time. So if you want to diagnose a patient's blood pressure and confirm that they have in-clinic hypertension or true hypertension, you need to order an out-of-clinic BP measure. If you're suspected that the patient has white coat hypertension, if you suspect that the patient has masked hypertension, you also need to order an out-of-clinic BP, because you cannot diagnose either white coat or masked hypertension with only in-clinic BP measurements. If you suspect that the patient has nocturnal hypertension, such as obstructive sleep apnea, chronic kidney disease, or diabetes history, then you need to do an ABPM, because there's no way a patient can measure blood pressure themselves when they're sleeping. And also if the patient has hypotension that's either postural or postprandial or drug induced. So why do we care about ABPM and HBPM? It's because ABPM and HBPM are actually better predictors of cardiovascular risk than clinic BP measurements. So the patient's blood pressure outside of the clinic is actually a better predictor of their risk of heart attacks, as an example, than measurements of blood pressure in the clinic. And so because it's more accurate and it's more better predictor of risk, treatment decisions for hypertension should ideally be based on ABPM and HBPM measurements when possible. However, the Australian Cardiovascular Disease Risk Calculator, which is this website here, they are only validated for use with in-clinic blood pressure readings. And so if you give this calculator here the readings based on a patient's out-of-office blood pressure measurement, you might underestimate the risk of cardiovascular disease if you use this calculator. Okay, now how do we diagnose? What is the diagnostic criteria of hypertension? So hypertension can be diagnosed through several different criteria. The first of which is clinic blood pressure readings of above 140/90, an ambulatory blood pressure monitor that has different criteria based on the average during the day, the average during the night, and a 24-hour average. A 24-hour average of more than 130/80, diagnosis of hypertension. A daytime average on the ambulatory blood pressure monitor of above 135/85 is diagnosis of hypertension, and the nighttime average of 120/70 is also diagnosis of hypertension. And the reason why the threshold for the nighttime criteria for diagnosing hypertension is low is because when you're sleeping, there should be a physiological drop in your blood pressure. We call that a dipping response in blood pressure. That's normal and that should happen. If a patient doesn't have that physiological drop in blood pressure of about 10% or so, they're called a non-dipper. And non-dippers are at high risk of cardiovascular disease. The home blood pressure monitor is exactly the same criteria as the daytime criteria for the ABPM, which is 135 or greater than 135/85. Okay, again, you need to diagnose hypertension, you need to have multiple measurements of blood pressure across multiple office visits. It can be, that's incorrect, it should be in or out. We prefer out-of-office blood pressure measurements if possible, so ABPM or HBPM, and if you have to pick between ABPM or HBPM, you prefer ABPM because that is more accurate. And you need to confirm any in-office BP readings that are in the hypertensive diagnostic criteria range with out-of-office blood pressure measurements, because in order to diagnose true hypertension, you need to make sure, as mentioned before, that the patient doesn't have masked hypertension or white coat hypertension. There are other diagnostic criteria to diagnose hypertension, but this is usually in a more acute setting, and it's less commonly seen. But other ways to diagnose hypertension without needing to have multiple measurements of this criteria here is that the patient presents with a hypertensive urgency or emergency. If the patient has a single reading of blood pressure above 180/120, or the patient has a blood pressure of greater than 160/100 with evidence of hypertensive target organ damage such as left ventricular hypertrophy, hypertensive retinopathy, cardiovascular disease, congestive heart failure, chronic kidney disease. So next we evaluate hypertension. The first part of evaluating hypertension is to confirm the diagnosis, as mentioned earlier. So if possible, we should confirm the patient's in-clinic hypertension readings with either out-of-clinic readings with ABPM or home blood pressure monitoring. If they're on any antihypertensive therapy, we want to review those ones as well. And we also want to identify any medications or any substances that can contribute to hypertension. Examples of medications that can contribute to hypertension include non-steroidal anti-inflammatories. They inhibit the COX enzyme, which reduces prostaglandins. And A reduction in prostaglandins leads to vasoconstriction and sodium retention. Stimulants, such as those used for ADHD and narcolepsy, so methylphenidate, dexamphetamine, and modafinil. The oral estrogens, which can be as part of the contraceptive pill or menopause hormone therapy. Corticosteroids, atypical antipsychotics. SNRIs, because they obviously contain noradrenaline, which noradrenaline reuptake inhibitors, and so they increase the noradrenaline level in the patient. And monoamine oxidase inhibitors likewise as well. Alcohol, energy drinks, caffeine, which is spelled with an E, and smoking can also contribute to hypertension. The next step is then assessing cardiovascular risk, because hypertension increases cardiovascular risk, and that's really why we care about hypertension. So we ask if they have any past history or any family history of cardiovascular disease, especially if they have a premature onset of cardiovascular disease, which is defined as having cardiovascular disease in men under 55 years of age and women under 65. We look for other risk factors for cardiovascular disease, such as hypertension, chronic kidney disease, diabetes, and dyslipidemia. And then based on these results, we can calculate the 10-year Australian atherosclerotic cardiovascular disease risk score. We then perform a social history assessing their lifestyle. We ask them about the SNAP factors, so smoking, nutrition, alcohol, and physical activity. And we also pay a lot of attention to weight and obesity. We assess for secondary hypertension if there's any indication for it. And here are some common causes of secondary hypertension, such as obstructive sleep apnea, primary hyperaldosteronism, hyper or hypothyroidism, pheochromocytoma, renal vascular disease, renal parenchymal disease, such as chronic kidney disease or glomerulonephritis, and Cushing syndrome. We will cover secondary hypertension in a little bit further down the line. As part of the exam, we do vital signs and BMI and waist circumference, which is usually standard for any patient in clinic. We do a cardiovascular exam and a respiratory exam, and we look at the carotids and the thyroid to assess for any bruits, to indicate any peripheral vascular disease, and thyroid as a secondary cause of hypertension. We then look specifically for any signs of target organ damage, such as left ventricular hypertrophy with a displaced apex, chronic kidney disease by doing a urinalysis looking for proteinuria or hematuria, heart failure, which will be pretty obvious. The patient will be quite overloaded. They have bivasal crepitations, peripheral edema, and they can have a raised JVP if they are quite full of fluid. Peripheral arterial disease, we do a lower limb vascular exam, so looking for pulses, color, capillary refill, sensation. And often forgotten is an eye exam, so to look for any signs of retinopathy, such as any retinal hemorrhages, any cotton wool spots, any AV nicking, and obviously papillary edema is a concerning finding, suggesting raised intracranial pressure from quite severe hypertension. We assess for target organ damage based on the clinical presentation. So if the patient presents with symptoms of heart failure or symptoms of peripheral arterial disease, such as intermittent claudication, then that's when we would do it. Otherwise, if the patient looks well, they don't have any symptoms from the hypertension, then there's no indication as such for you to go looking for these things on the physical exam. Although I think to be thorough, important to cover the exam quite well. So assessing for target organ damage is usually only relevant in hypertensive urgencies and emergencies. So the patient, for example, has a very high blood pressure above 180 systolic, for example, or 110 diastolic, then that's when we would be more suspicious of target organ damage. So what do we order in terms of investigations for hypertension? So we order a urine sample for all patients. The first is a dipstick, where we look for any proteinuria, and the guidelines will say send for microscopy if abnormal, as per the Hypertension 2016 guidelines, but as per the chronic kidney disease primary care guidelines, hypertension is a risk factor for chronic kidney disease, and every patient with hypertension should also get a kidney health check, which includes a urine albumin creatinine ratio in a first void spot sample in the morning. And that is to look for albuminuria, with microalbuminuria defined as an albumin creatinine ratio of greater than 3, and macro is a ratio greater than 30. We order blood tests for all patients with hypertension. So that will be fasting glucose and fasting lipid profile. That's part of the cardiovascular disease risk assessment for a patient. UEC to look at renal function as a consequence or a cause of the hypertension. FPE to look for any anemia, and thyroid function tests as well, as those of you can identify hyper or hypothyroidism very easily based on a simple blood test. We do a 12-lead ECG for all patients with hypertension, and this is to evaluate left ventricular hypertrophy. I don't know why there's an N there. Additional investigations will be as clinically indicated. So in echocardiography, if you suspect LVH based on your exam, place apex beat or really peak R waves on the ECG, or if the patient has AF or heart failure. But you're doing it more so because the patient has AF or heart failure rather than hypertension. A carotid ultrasound or the carotid ultrasound. A carotid ultrasound, if you suspect that the patient has carotid artery stenosis, such as carotid bruit. Renal artery duplex ultrasound, if you suspect that the patient has renovascular hypertension, such as if there's presence of renal bruit on an exam, or if they have a significant history of atherosclerotic disease, such as if they have coronary artery disease or peripheral arterial disease, because if they have lipid plaques in the coronary arteries or the peripheral arterial system in the limbs, then it's also possible that they have significant atherosclerosis in the renal arteries. The ankle brachial index is, you do it if there is a suspicion for peripheral arterial disease. So as mentioned before, claudication, reduced peripheral pulses, diabetes, smokers. The aldosterone-renin ratio, if you suspect Conn syndrome, in patients with moderate severe hypertension, patients with resistant hypertension, or in any patient with hypertension and an unexplained hypokalemia. Serum metanephrines, if you suspect pheochromocytoma, which usually presents quite strongly clinically with paroxysms of headache, sweats, and flushing. So we'll cover secondary hypertension briefly as well. So secondary hypertension is obviously hypertension that's caused by a secondary cause. And the most common cause of secondary hypertension in adults is primary aldosteronism. When evaluating patients with secondary hypertension, we should always exclude drug-induced hypertension, such as those caused by NSAIDs, steroids, COCPs, things like that. We prefer to investigate a patient for secondary hypertension prior to starting therapy, if possible, and this is because looking for mainly primary aldosteronism will be influenced by the antihypertensive meds. To screen for primary hyperaldosteronism, you look at the aldosterone-renin ratio, and several medications such as ACE inhibitors, ARBs, beta blockers, calcium channel blockers, all influence the ARR, the aldosterone-renin ratio. When we would recommend screening for secondary hypertension, if we suspect a patient has secondary hypertension, we typically screen for renal disease, so both parenchymal and renovascular disease. We screen for primary aldosteronism and obstructive sleep apnea. For the rarer causes, such as pheochromocytoma or Cushing's syndrome, we only investigate if there is a clinical suspicion rather than a blanket ordering of tests just because the patient has secondary hypertension, because the clinical yield of having a positive finding for pheochromocytoma or Cushing's is low unless there are clinical features to suggest those as a cause. So when do we suspect secondary hypertension? We suspect secondary hypertension if the patient has resistant hypertension, and again that is defined as a blood pressure above target, usually 140/90 on 3 separate classes of drugs, one of which is a diuretic. We also suspect secondary hypertension in patients who have hypertension younger than the age of 40, especially if they don't have any obesity or a strong family history. We also suspect if they have severe hypertension or if they have clinical features suggesting a secondary cause, such as daytime somnolence for obstructive sleep apnea, headache, sweats, flushing, or tachycardia for pheochromocytoma, or moon phases, buffalo hump, central adiposity, or abdominal striae for Cushing's. If they have abnormal labs such as proteinuria, hematuria, or hypokalemia that you can't explain with another cause, or if they have a 30% greater than 30% creatinine rise after starting ACE inhibitor or angiotensin receptor blockers, and this is suspicious for renal artery stenosis. Very rarely you can suspect secondary hypertension if a patient has abnormal imaging with hypertension, and the main one that is relevant is finding of an incidental adrenaloma that can point towards primary aldosteronism. So we'll go through the causes and key features clinically of several causes of secondary hypertension. So the first is renovascular disease, and that's renal artery stenosis. In younger patients, it's caused by fibromuscular dysplasia, whereas in older patients, it's more likely to be atherosclerotic disease. And we suspect renal artery stenosis when there is a worsening renal function with a rise of creatinine, as mentioned before, of greater than 30% after initiation of an ACE inhibitor or an ARB. You can also suspect it based on an abdominal bruit on examination, though I've never come across that in my life. And the investigation of choice, if you suspect renal vascular disease, is a UEC, urinalysis, urine ACR, and importantly, a renal artery duplex ultrasound. For renal parenchymal disease, those are glomerulonephritis, polycystic kidney disease, chronic kidney disease, usually stage 3B or 4 onwards. You suspect them if they have hematuria and proteinuria, or if they present with recurrent UTIs, because that can cause renal damage, and any structural abnormality of the kidneys, such as with polycystic kidney disease, can predispose to recurrent UTIs, or if they also have a family history of polycystic kidney disease. The investigation is similar for renal vascular disease, minus the renal artery duplex ultrasound. You do a UEC, you do a urinalysis, a urine ACR, and imaging such as an ultrasound KUB to look for any structural abnormalities with the kidneys. Primary aldosteronism, the most common cause of secondary hypertension. There's two different ways that you can develop primary aldosteronism. The first is by having an aldosterone producing adenoma, and the management for that is surgery usually, or you have bilateral adrenal hyperplasia, and the management of that is medical therapy with mineralocorticoid receptor antagonists. Primary aldosteronism usually presents with hypokalemia, and the investigation of choice is a UEC with an aldosterone-renin ratio. We measure the aldosterone-renin ratio in the morning, 2 hours after they wake, which is usually at 10 a.m. because most lab places open at 8, and there's no need to fast. We need to ensure that the patient is normokalemic and that the potassium is between 4 and 5 for about 4 to 6 weeks or so. And this is because a patient with hyper or hypokalemia can influence and distort the ARR levels. If you have hyperkalemia, what happens is the body will try to increase aldosterone levels to kick out the potassium from the body. And on the opposite side of things, if you have hypokalemia, the body will decrease aldosterone levels to minimize the loss of potassium through the kidneys. The positive result of the aldosterone-renin ratio is a result of greater than 70, and you should withhold interfering medications for 2 to 6 weeks if the patient is already on these medications prior to you ordering the test. So medications that you must replace include loop diuretics, thiazides, and mineraloreceptor antagonists. Obviously, whether or not you replace them or stop them depends on the clinical appropriateness. For example, if they have another stronger indication to remain on these medications, then you probably won't stop them. And if that's the case, you refer them to an endocrinologist for further testing. Group 2 is replaced if possible, and that's ACE inhibitors, ARBs, and dihydropyridine calcium channel blockers like amlodipine or lecanidipine. Group 3 will be the beta blockers, not as important, but you should replace them if you can as well. If you stop these groups of blood pressure medications in your patients, then obviously their blood pressure will rebound and go up. And so you want to replace these medications with non-interfering options if clinically appropriate, so they don't have any contraindications. It's safe in order to help control their blood pressure. And the medications that don't interfere with the ARR is verapamil, moxonidine, or prazosin. Cushing syndrome. So Cushing syndrome presents with wide purple striae on examination, proximal myopathy, easy bruising. They have the classic textbook features of central obesity, moon phases, and buffalo hump, which usually does not always present, and it can be quite difficult to pick out. Or if they have new onset diabetes, that's quite severe. The investigation of choice for Cushing syndrome is a late night salivary cortisol or a 24-hour urinary cortisol. And you need to get 2 samples of each in order to ensure that it's not due to an isolated error. The last test that you can order is also a 1 milligram overnight dexamethasone suppression test. Pheochromocytoma, paroxysms of headache, palpitations, and sweating, and investigations of serum methanephrin, as mentioned before. Thyroid dysfunctions or hypothyroidism obviously presents with symptoms of hyper or hypothyroidism, so weight, appetite changes, bowel habit changes, intolerances to heat, cold, fatigue, and the investigation is thyroid function tests. Obstructive sleep apnea, they will present with snoring, daytime somnolence, and the investigation choice is a polysomnography or also known as a sleep study. So what is the management of hypertension? So we start with lifestyle management first, which is physical activity. And the guidelines recommend 150 to 300 minutes per week of moderate intensity, or 75 to 150 minutes per week of vigorous intensity. We should aim to have muscle strengthening exercises on at least 2 days per week. And the important reminder is that any activity is better than no activity. For weight management, we try to aim for a target BMI of less than 25 and a waist circumference in Caucasians of less than 94 centimeters in males and less than 80 centimeters in females. The waist circumference targets will be different for Asian populations and African populations as well. A low salt diet is very important for management of hypertension. For primary prevention, so patient doesn't have any cardiovascular disease, we aim for a salt content of less than 5 grams per day. That is salt content rather than sodium. We also aim for a salt content of less than 4 grams per day if the patient has cardiovascular disease, so that is for secondary prevention. Preferably, if we can, we should aim for less than 2 milligrams of sodium per day, which is roughly equivalent to less than 4 grams of salt per day, because that is more effective in reducing blood pressure than a higher salt diet. And so the way to achieve a low salt diet is by choosing low salt food options or no salt food options. And low salt food options are those that contain less than 400 milligrams of sodium over 100 grams of whatever the food is. We also advise patients to limit processed and packaged foods, and we also advise them to substitute salt with other seasonings if possible, and to not add any table salt to their meals when they're sitting at the dining table. Okay, so this here is the information sheet that you can pass on to patients to help reduce salt in their diet. So next is diet. Apart from salt, there's also the dietary approaches to stopping hypertension. So that is very similar to a low salt diet, but is a bit more thorough in terms of encompassing things like increasing fiber intake with vegetables and fruits, having more legumes and poultry, lean meats, things like that, and minimizing intake of saturated fats and sweets and processed foods. Okay, so we want to limit total fat to 20 to 30% of the total energy intake, which means limiting fried food to about less than once a week. As mentioned before, limit foods high in saturated fat, added salt and added sugars, vegetables at least 5 servings a day, and fruits at least 2 servings a day. You can roughly gauge the serving size based on the patient's size of their palm. Smoking and alcohol is obvious. Try to stop smoking, minimize alcohol as much as possible, and the aim for alcohol is less than 2 standard drinks a day. So pharmacotherapy. So when do we start medications? So to start medications, it is dependent on the patient's blood pressure level and their absolute cardiovascular disease risk. So these are the thresholds for when we are recommended to start medications. So if the patient has established cardiovascular disease, unless it is clinically appropriate where they are hypotensive, systolic less than 100 for example, then we recommend to start medication. And as per therapeutic guidelines, the recommendation for patients with cardiovascular disease is an ACE inhibitor or an ARB if an ACE inhibitor is not tolerated. If they have high cardiovascular disease risk as per the atherosclerotic CVD risk calculator, then you should start them on on blood pressure medications, again unless it is clinically inappropriate to do so. If they are intermediate risk, which is between 5 to 10%, high risk is above 10%, intermediate is 5 to 10%, then we usually aim to start medications if their blood pressure is persistently above 140/90. And this is again after shared decision making of your patient, perhaps after a trial of lifestyle. Low CVD risk, less 5% or less. Usually we would lean towards starting blood pressure medications if their blood pressure is persistently greater than 160 systolic or 100 diastolic. You can start at a lower threshold, for example, above 140 or 90, but that again depends on a shared decision-making process that you make with your patient. For patients with low CVD risk, you're not routinely treated with medications, and that is because the benefit of antihypertensives is not as great, and you still get the same amount of risks in terms of possible side effects. But of course, if their blood pressure is high, greater than 160 over 100, then the benefit will be greater. As we know, the higher your blood pressure, the higher your risk of developing cardiovascular disease, even if your risk calculator says that they are low. So here's the treatment decision aid from the 2016 guidelines. So the first is to assess the patient's cardiovascular disease risk assessment. The eligible adults for the calculator will be aged of 45 years or greater, or if they're Aboriginal and Torres Strait Islander, the age for eligibility is lower, 35 and above, and so anyone else will not be eligible for that. The risk assessment is recommended for the following individuals without atherosclerotic cardiovascular disease. So all people aged 45 to 79, people with diabetes aged 35 to 79, or First Nations people aged 30 to 79. So this guideline is actually outdated. And so it says here, establish if the patient is considered high risk. It says more than 15% chance in the next 5 years. That has now reduced to 10% if the new calculator that was released in 2023. And adults with any of the following do not require an absolute CVD risk assessment, as they are already considered high risk. So in the 2016 guidelines, they will say anyone with diabetes. With the old CVD risk calculator guidelines, they recommend that anyone with diabetes and above 60 years of age are high risk. That's not necessarily the case now with the new guidelines. If you do have a patient above 60 and diabetes and you plug them into this calculator, you can see there's a segment for diabetes where you look at their duration of diagnosis, HbA1c, urine ACR, eGFR, BMI, and whether they're using insulin. That will help you calculate the CVD risk. From most of the time when a patient is above 60 and they have some level of poorly controlled diabetes, they will tend to be at least intermediate, if not high risk anyways. And so there is some overlap between the old and the new guidelines, but the new guidelines is not a catch-all that everyone with diabetes and 60 plus is high risk. Again, and that's also the same with the next point, diabetes with microalbuminuria is not necessarily high risk. What is high risk is if they have macroalbuminuria. So you can see here if they have a persistent urine ACR of more than 25 in men or 35 in women, those will automatically be considered as high risk. Moderate or severe chronic kidney disease, as defined by a urine ACR above 25 or 35 for males and females respectively, and that's the same as the new guidelines, or if they have an eGFR of under 45. That is also the same as the new guidelines. As you can see here, patients that are automatically considered to be at high risk of CVD is a sustained eGFR of less than 45. Patients with familial hypercholesterolemia, that is the same as the new guidelines. Again, jumping back here, you can say here, familial hypercholesterolemia. If they have a systolic blood pressure of above 180 or a diastolic blood pressure of greater than 110. So again, that's not necessarily true with this new guidelines. I mean, the higher the blood pressure, the higher they are to have greater CVD risk, but just because the patient has 180 systolic or 110 diastolic does not mean they automatically qualify as high risk under the new guidelines. A serum total cholesterol of greater than 7.5, again, this is not necessarily the case where they have high risk in the new guidelines, but if they have a total cholesterol over 7.5, you would start a statin anyways. And again, Aboriginal Torres Strait Islander above 74 years of age, that is not part of the new guidelines, but of course it does indicate that they are likely to be at risk. So there's a few differences between the new and old cardiovascular disease risk guidelines. So after that, we calculate their risk, and then we get a number, low risk, intermediate risk, or high risk. So here's a flowchart from the 2016 guidelines. So we check the eligibility for absolute risk assessment, and then we conduct the CVD risk assessment on the website. If they're high risk, now it's 10%, not 15%, then we start immediate drug treatment. If they're at intermediate risk, the new guidelines is 5 to 10%, not 10 to 15. And we recommend starting medications if the patient is happy to after shared decision making, or if they also have any of the following. So blood pressure of greater than 160 or 100, or if they have any other risk factors that puts them at high cardiovascular disease risk. So we start drug treatment if they have intermediate risk, usually unless the patient doesn't want to, but more so if the patient has a high blood pressure of 160 on 100. If they're at low risk, then usually we don't start them on medication unless their blood pressure is persistently above 160 over 100, or if their blood pressure is not greater than 160 over 100, so between 140 and 160, but the patient wants to start it after shared decision making. So in summary, high risk, you start the medication. Intermediate risk, usually you start the medication. You would consider starting it even more if their blood pressure is above 160 on 100, or if they have any other risk factors that raises their cardiovascular disease risk, as it can bump them into a high risk category, or if they've tried lifestyle and it doesn't work after shared decision making. Likewise, with low risk, we don't usually start medications unless their blood pressure is elevated above 160 or 100, or if the patient is happy to start it at a lower threshold after shared decision making. If we do start medication, or when we do start medication, we aim for a traditional blood pressure target of 140 over 90. So everyone, usually with hypertension, we want to aim for less than 140 over 90. We know that if we lower the BP, we lower the cardiovascular disease risk, but there's also an increased risk of adverse effects, such as because you need to use more doses of a medication to get to that point. And side effects of medications include hypertension, syncope, acute kidney injury, and electrolyte abnormalities. And so the general recommendation is that we treat all patients to a target of less than 140 systolic and less than 90 diastolic. And the target will be lower if they have comorbidities which necessitate a more tighter blood pressure control. So for example, if they have a history of atherosclerotic cardiovascular disease, then we prefer the target to be less than 130 over 80. You can aim for a lower systolic of less than 120 if the patient can tolerate it. If they're at high CVD risk, and this is as per ETG and the CVD risk calculator, we prefer less than 130 over 80 as well, even if they don't have any comorbidities. Less aggressive targets are okay if they have adverse effects, such as they get postural hypertension, or if they are elderly, because they're more likely to be sensitive to kidney injury, electrolyte abnormalities, and postural hypotension. What antihypertensives do we use? So the first line is recommended by the guidelines and as per therapeutic guidelines is an ACE inhibitor or an ARB, a thiazide diuretics, or a dihydropyridine calcium channel blockers. In terms of their efficacy of lowering blood pressure, all three of these have similar efficacy as monotherapy. We also take into account a patient's comorbidities to guide the choice of medications, such as an ACE inhibitor for patients with heart failure with reduced ejection fraction, chronic kidney disease, or a post-MI patient, or dihydropyridine calcium channel blockers if they have angina. We avoid beta blockers as a first-line medication and as monotherapy in patients with uncomplicated hypertension because they are not as effective as the other three classes and they carry more side effects. So how do we escalate antihypertensives? So the usual regimen is to start the patient on a low to moderate dose of drug 1, and that's usually an ACE inhibitor or an ARB. If the target is not reached after 3 months, then we add a second drug. So that's either a calcium channel blocker or a thiazide diuretic. And we prefer to add a second class. We prefer to add a second drug from a different class because it achieves better efficacy in lowering blood pressure while minimizing any dose-related side effects from increasing the dose of the first drug. If we still have uncontrolled blood pressure after 3 months of drug 1 and drug 2, then we up-titrate drug 1 or drug 2 to a moderate dose. If it's still uncontrolled after 3 months, then we up-titrate the other drug that we didn't up-titrate earlier. If it is still uncontrolled, then we add a third drug. And at this point, we will be asking ourselves, why does the patient still have high blood pressure despite 2 drugs not being effective? And that is maybe adherence issues, they could have secondary hypertension, or they could have contributing medications and substances that are raising their blood pressure. Or we could just be measuring their blood pressure wrongly, though that's not very common. If it is still uncontrolled on 3 drugs, then we refer them to a tertiary specialist. And usually the fourth drug that is added to control the blood pressure is spironolactone or an MRA. Other drugs that may be used include clonidine, metildopa, moxonidine, prazosin, and beta blockers. Whenever you start or dose adjust antihypertensive, it takes about 4 to 6 weeks for the maximum effect of that drug to be seen. So we don't make any changes until at least 4 to 6 weeks after a previous change. So combination therapy is where you start the patient on 2 drugs instead of 1. And you can consider starting combination therapy if the patient's blood pressure is greater than 20 systolic or 10 diastolic above their target. So if the patient has a systolic or a diastolic of 160 on 100 or greater respectively, then that is an indication to start them on combination therapy. The preferred combination is an ACE inhibitor and a calcium channel blocker, that is amlodipine or lecandidipine, because it has better cardiovascular disease outcomes compared to an ACE inhibitor with a thiazide diuretic. The benefits of combination therapy is that it is more effective than doubling the dose of a single drug, and you achieve a faster and greater reduction in blood pressure. However, the risk is that if the patient develops any adverse effects, it can be difficult to pinpoint which is the complicit medication. So for example, if the patient develops postural hypotension, is it because of the ACE inhibitor, or is it because of the calcium channel blocker, or is it because the blood pressure is reduced too quickly, too soon, too quickly? The other risk of combination therapy is that it also increases the development of side effects. So these are effective drug combinations that you can use, although preference is usually for an ACE inhibitor and a calcium channel blocker. But you can use an ACE inhibitor and a thiazide diuretic, especially in patients with heart failure. ACE inhibitor and calcium channel blocker can be useful for patients with lipid abnormalities or diabetes, because thiazide diuretics do have a very small risk of impaired glucose tolerance and impaired lipid tolerance. ACE inhibitor or plus a beta blocker, again, I wouldn't use a beta blocker as a first line. There's no reason for me to use a beta blocker ahead of a thiazide or a calcium channel blocker. And the bottom 3 here, I don't really care about except for the thiazide and the calcium channel blocker. But usually we prefer an ACE or an ARB. Combinations to use with care will be diltiazem and a beta blocker because of a risk of heart block. Verapamil also has a similar effect too, but combinations to use with care will be a non-dihydropyridine calcium channel blocker such as diltiazem and verapamil with a beta blocker, because it increases the risk of heart block and significant bradycardia. We also don't combine ACE inhibitors with ARBs because they don't achieve anything extra and they increase the risk of adverse effects, both in cardiovascular disease mortality and acute kidney injury. We also try to be cautious when we combine an ACE inhibitor or with spironolactone due to the risk of hyperkalemia, although both ACE inhibitor and Spiro are used together very commonly, for example in patients with heart failure. If the patient needs combination therapy, we prefer them to take single pill combinations, so when one pill has 2 medications. Better blood pressure control than if you take the same medication in 2 separate pills. It improves adherence. The patient only needs to take 1 pill instead of 2, and it's more effective than 2 separate pills. Now, when a patient has hypertension, they may also have other comorbidities, and depending on their comorbidities, it will influence the choice of antihypertensive that you choose. So if the patient has chronic kidney disease, then we prefer an ACE inhibitor or an ARB because they are renal protective. If the patient has albuminuria, then we definitely prefer an ACE inhibitor or an ARB. And the target is less than 140/90 for chronic kidney disease. And if they have albuminuria, less than 130/80 is the target. If the patient has diabetes, then we prefer ACE inhibitor and ARB, mainly for renal protection effects, because we know diabetes is a significant risk factor for the development of chronic kidney disease. If they have albuminuria, then again, we definitely prefer an ACE inhibitor or an ARB. The target for diabetes will be less than 140/90, though you can aim for a lower blood pressure target if the patient tolerates it. Post myocardial infarction, every patient will be on an ACE inhibitor or an ARB plus or minus a beta blocker. And the target for cardiovascular disease with hypertension is less than 130/80. If they have heart failure, for example, if they have HFrEF, so heart failure with reduced ejection fraction, then they'll be on the 4 pillars of ACE inhibitor or an ARB or an ARNI with a beta blocker plus an MRA plus an SGLT2 inhibitor. And the target blood pressure for heart failure is less than 130/80. For stroke, there is no specific medications actually. Any first-line agent is okay. So that's an ARB, ACE inhibitor, thiazide diuretic, or a calcium channel blocker. I believe that thiazide diuretics tend to have some more data to lower the risk of stroke, but it is not significant, I guess, enough to recommend it ahead of any other of the ACE inhibitor or calcium channel blockers. And the target is less than, again, 130/80 because they have cardiovascular disease risk. This here's a table from UpToDate which essentially summarizes it. So HFrEF, ACE inhibitor or an ARB, beta blocker diuretic MRAs, post-MI ACE inhibitor or an ARB with a beta blocker. If they have proteinuria CKD, ACE inhibitor or an ARB. If they have angina, then beta blocker or a calcium channel blocker. If the patient also has AF, then they will be on rate control medications with a beta blocker or a non-dihydropyridine calcium channel blocker like verapamil or diltiazem, similar for atrial flutter. And if they have hypokalemia, then an aldosterone antagonist or a mineralocorticoid receptor antagonist like spironolactone will have more benefit. There are also certain other medical conditions that may be beneficial for patients depending on the antihypertensive of choice. So for example, if a patient has benign prostatic hyperplasia, then if they need to have an alpha blocker, then if they need extra medications to help control their blood pressure, then you would typically choose an alpha blocker. But of course, if they have BPH, you would not use an alpha blocker ahead of an ACE-ARB calcium channel blocker or a diuretic. Essential tremor, beta blocker, hyperthyroidism, beta blocker, migraine, beta blocker as prophylaxis, although candesartan now can also be used as migraine prophylaxis. So monitoring. So once we start the patient on a blood pressure medication or we change the dose, we review them 4 to 6 weeks later. We assess their BP response, so the efficacy, we assess the adherence, and we assess any side effects. We want to check electrolytes and creatinine at baseline before they start medications, and then about 2 to 4 weeks after starting a dose change, after starting or having a dose change. And that's because we want to pick up any AKI, any hyperkalemia or hypokalemia, and their creatinine. We also do an annual CVD and CKD health check, so checking other risk factors for cardiovascular disease, like lipids, blood sugar. And we also do a CKD health check with checking their blood pressure and urine ACR and AUEC. We also ask the patient to check their blood pressure at home if they are able to do so. So what about some side effects for antihypertensive medications that we should be aware about? So we'll start with ACE inhibitor and the angiotensin receptor blockers. So ACE inhibitors and ARBs. Here are some examples: ramipril, perindopril, candesartan, telmisartan. They can worsen bilateral renal artery stenosis, so we're cautious with that. If they have a history of angioedema, we typically don't use ACE inhibitors or ARBs. If they have hyperkalemia, then we try not to start them until they are normokalemic. And if they have, and they can also have a risk of developing AKI, where we expect there to be a rise in creatinine after starting an ACE inhibitor or an ARB, which is to be expected, but we don't want it to be too high. So we aim for a less than 25% increase in creatinine. So ACE inhibitor or an ARB can also cause AKI. There is expected to be a small rise in creatinine when we start the patient on an ACE inhibitor or an ARB, but we don't expect that rise to be greater than 25%. There's a greater risk of developing AKI in patients starting an ACE inhibitor or an ARB if they are concurrently using other nephrotoxics such as non-steroidal anti-inflammatories. If the patient develops a creatinine rise that's greater than 30% and it continues to rise, then we need to be suspicious of the patient possibly having renal vascular disease. A possible side effect of ACE and ARBs is cough, which is more prevalent in ACE inhibitors than ARBs. Dihydrocalcium channel blockers, examples are amlodipine and lecanidipine. The main side effect that most people know about is peripheral edema, and the peripheral edema is due to fluid redistribution rather than hypervolemia, and so treating it with diuretics is useless. and causes harm to the patient. The management of peripheral edema from amlodipine is to either reduce the dose, because it is dose dependent. You can switch to a different antihypertensive class, or you can add an ACE inhibitor or an ARB. And the way that works is because ACE inhibitors and ARBs, they cause arteriolar dilation, but they also cause venodilation. So peripheral edema occurs when blood leaks out of the capillaries into the extravascular tissue, and blood will travel, and for the blood to get to the capillaries, they go from the arterioles to the capillaries, and then from the capillaries into the venules. And so by causing venodilation, it reduces the pressure in the venules, and therefore this causes a pressure gradient to have more blood be driven from the arteriole across the capillaries into the venules. And so there is less blood sitting in the capillaries, and therefore the capillary pressure decreases, and therefore there is a decreased extravasation of blood into the extracellular tissues because of the venodilation that is achieved by an ACE inhibitor or an ARB. Other common side effects of amlodipine include headache, lightheadedness, and flushing, and uncommonly it can also cause gingival hyperplasia. If that's the case, usually you would stop the medication. Thiazide diuretics, examples are chlorthalidone, indapamide, and hydrochlorothiazide, or HCT. They can cause impaired glucose tolerance. They can also cause hyperuricemia, and so if a patient has gout, you have to be quite cautious with thiazide diuretics. They can also cause hyponatremia, hypokalemia, hypomagnesemia, and generally we prefer chlorthalidone or indapamide over HCT because chlorthalidone and indapamide, there's more evidence to suggest that they are better antihypertensive in terms of their efficacy in lowering blood pressure compared to HCT. Potassium sparing diuretics, spironolactone is one, eplerenone is another. The main side effect we know about is hyperkalemia, so if their potassium is 5 or greater, we avoid using it, and they can also cause anti-androgenic side effects with spironolactone, such as gynecomastia. Non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, although I don't believe diltiazem is TGA indicated for hypertension. Side effects will be constipation, bradycardia, heart block. We shouldn't use verapamil or diltiazem in patients with heart failure because they are negative ionotropes, and so you will depress the heart function even more. And similar to the dihydropyridine calcium channel blockers, they can cause gingival hyperplasia. Beta blockers such as atenolol or carvedilol, we don't recommend it for monotherapy for hypertension as mentioned before. They can cause bradycardia, they can have heart block if you combine them with verapamil or diltiazem, and they can also cause bronchospasm. If you have a patient with a history of asthma or COPD and they need to be on a beta blocker, then usually you would do a non-selective beta blocker or a cardioselective beta blocker such as bisoprolol or nebivolol. Alpha blockers will be prazosin, tamsulosin is also the other. The main drawback of alpha blockers is they can cause quite significant postural hypotension, more so in the elderly, but it's useful if they have BPH as well, though BPH is not a catch-all reason to start prazosin for a patient with hypertension. The central alpha-2 agonists, as we mentioned before, stimulation of the alpha-2 receptors causes vasodilation, and so these medications help with reducing blood pressure by causing reduced TPR, total peripheral resistance. Examples are clonidine, moxonidine, and metildopa. The main drawbacks is that if you suddenly stop the medication, it can cause quite significant rebound hypertension, and this rebound hypertension can be quite severe and lead to target organ damage. So if you need to stop these medications, similar to beta blockers, you need to wean them off slowly. Metildopa is usually the antihypertensive we use in pregnancy, and other side effects will be dry mouth and sedation. So here are some contraindications from UpToDate. So angioedema, we don't use an ACE inhibitor. Bronchospasm, we do not use a non-selective beta blocker. If the patient is at risk of pregnancy sounds like pregnancy is a disease, but if the patient has a possibility of being pregnant, then we don't use an ACE inhibitor or an ARB because they are teratogenic. If the patient has heart block, especially high degree heart block, second, type 2 morbids or third degree heart block, then we don't use a beta blocker or a calcium channel blockers like verapamil or the diazepam, and then others that we generally avoid. If they have depression, then we avoid beta blocker or alpha-2 agonists because they have a very depressive effect. Gout, avoid loop or thiazide diuretics. Hyperkalemia, generally avoid aldosterone antagonists, ACE or ARBs. Hyponatremia, avoid thiazide diuretics. So we'll talk a bit more about ACE inhibitors and ARBs because they are usually the first line medication that they will use. And so I think it's important to know a bit more about their side effects. So common adverse effects, similar to any other medication, antihypertensive, it's hypotension. They can also cause acute kidney injury, hyperkalemia, cough, less so with ARB, and angioedema, less so with ARB. Regarding acute kidney injury, an ACE inhibitor and ARB can cause serum creatinine to rise by 5 to 25%. If it rises above 30% more than baseline, then we stop. And the risk factors for developing AKI with an ACE inhibitor or an ARB are bilateral renal artery stenosis. And so these are usually patients with quite severe atherosclerotic vascular disease. The patient has chronic kidney disease, heart failure, or if they're using other nephrotoxics. For hyperkalemia, ACE inhibitors and ARBs, it usually increase potassium by less than 0.5 millimoles per liter if the patient has normal renal function. So risk factors for developing hyperkalemia, where their potassium rises more than 0.5, such that it brings them to be above 5, will be chronic kidney disease, concurrent potassium-sparing drug use, so spironolactone, or the use of NSAIDs. Regarding the cough, it occurs in about 5 to 20% of patients taking an ACE inhibitor. It is less common with ARBs, but can still happen. And it usually develops within the second week after starting an ACE inhibitor, but this can be delayed by up to 6 months. So if a patient presents with a dry, irritating cough that happens within 6 months of starting an ACE inhibitor, then you have to think of the ACE inhibitor as the cause. Interestingly, cough as a side effect of the ACE inhibitor is more common in females, and it resolves within 1 week of stopping, but it can be a bit slow in some patients, taking up to 4 weeks for it to go away. And if you restart them on an ACE inhibitor again, their cough will return again. And the management, if a patient develops a cough on an ACE inhibitor, is to switch it to an ARB. And if they still get a cough on an ARB, then it depends on whether or not they can tolerate the cough. If they can't, which is usually the case, then you can't use the ARB. So what about tapering antihypertensives? Most patients require lifelong therapy. Some patients can be considered for tapering, and these will be patients who experience adverse effects such as hypotension, or if they are consistently at blood pressure target without any target organ damage. We do not taper antihypertensives if the patient has target organ damage, even if the blood pressure is at goal, because then the blood pressure medications are usually not for blood pressure, although it's important to control their blood pressure, but more so for secondary prevention of cardiovascular disease. Positive factors that will predict more successful tapering is if they have a lower baseline blood pressure prior to starting treatment, if they have good adherence to lifestyle, or they are younger. The benefits of tapering is that there is less polypharmacy and there's less risk of side effects. But the risk of tapering is that you can have a worse cardiovascular disease outcome or recurrence or worsening of their hypertension. But if you decide that this patient is safe to taper, how do we taper? We reduce one medication at a time if they're on combination therapy, and we halve the dose every 1 to 2 weeks. We monitor their blood pressure throughout during the taper, and even after they've stopped, it is also important to continue to monitor their blood pressure. If they have a normal blood pressure for more than 3 months after you've tapered all their antihypertensives, then it is a successful taper and the patient may remain off the medication. But if the high blood pressure reoccurs, which is usually the case and more common than them being successful, then we want to restart the antihypertensives. There is a withdrawal risk with some agents, such as the alpha-2 agonists and beta blockers. And so if you stop it suddenly, it can cause rebound hypertension. And so we wean these medications by reducing the dose by half every 1 to 2 weeks, which is usually what we do anyways for any antihypertensive, but it is more important to do so with these medications. Lastly, How do we manage a patient with resistant hypertension? The first thing to do is to try and understand why they have resistant hypertension. So do they have a secondary cause? If so, we should identify and treat it. We should try to stop any medications that can increase a patient's blood pressure. If it is clinically appropriate, we need to ensure that they are keeping up with lifestyle treatment. We need to address any possible non-adherence, both to medication and lifestyle. And of course, if they have resistant hypertension, we need to escalate their pharmacotherapy to get their blood pressure under control. So typically, the patient with resistant hypertension, by definition, will already be on an ACE inhibitor or an ARB, plus a calcium channel blocker like amlodipine, plus a thiazide diuretic. If the thiazide diuretic that the patient is on is HCT, then we should switch them to indapamide or chlorthalidone because it is more effective than HCT at lowering blood pressure. Otherwise, if the patient is already on all three, then we add an MRA. And again, we check the potassium in 2 to 4 weeks after starting to make sure that the patient doesn't develop hyperkalemia. If they are still uncontrolled on 4 drugs, then they will usually be involved with a specialist already, and the specialist may recommend, or if you're comfortable as a GP, you can also add another class such as clonidine, moxonidine, or a beta blocker. Done.